this is a very exciting time for prostate cancer. In the past 18 months, there's been 3 drugs that have been approved for prostate cancer, rapidly changing the paradigm for treatment. We see other new exciting agents that are being explored, and today's talk will be exploring some of these agents and how to approach castrate-resistant prostate cancer. In 2005, we found that chemotherapy was finally shown to be effective in the treatment of castrate-resistant metastatic prostate cancer. That drug was docetaxel, which showed that the median survival was 19.2 months, and 17% of patients had a 3-year survival. Most importantly, chemotherapy for prostate cancer showed that it improved the quality of life for patients as well as decreased pain symptoms. When we look at the variety of agents that are available, it takes a coordinated effort in terms of what's the most appropriate timing of these treatments. I personally like to use the clinical states model, which is an effective model to look at where patients stand, where they stand with their disease with castrate-resistant metastatic prostate cancer. When we look at the clinical states model, it has the physician look at where the patient stands with their disease, and this is especially important now in prostate cancer. Patients have now who become castrate-resistant, older terms that were used, androgen-dependent or hormone refractory, now have a wide variety of options. Most importantly, in those patients who have metastatic disease, there are many agents, which we'll summarize today, that have shown a survival benefit and a control of their symptoms. The first question I think that should be asked is the patient symptomatic or the patient without any symptoms? So when we look at metastatic disease, many things are important in terms of if the patient's symptomatic or asymptomatic. And that's important today now that we have multiple clinical trials looking at asymptomatic castrate-resistant prostate cancer. And in addition, the introduction of Provenge in this space is also very important for patients. And basically, allowing patients not necessarily have to start chemotherapy in order to get their disease under control. So a patient likely needs chemotherapy if the certain clinical characteristics are present. One, if the PSA nadir is greater than 4, and that is if someone gets started on androgen deprivation therapy and they have metastatic disease. If they fail to achieve a PSA nadir greater than 4, it is prognostic in terms of the outcome. In those patients who have a slowly rising or rapid rising PSA level, the absolute PSA and the PSA doubling time is also very informative. Andrew Armstrong looked at 4 characteristics in retrospectively reviewing the TAX-327 trial, which was a definitive trial showing the efficacy of docetaxel, that there were 4 prognostic factors. 1, if patients had metastatic disease to liver, they had a worse outcome. If they had pain that was associated with their prostate cancer requiring narcotics, they had a worse outcome. If they had a low hemoglobin associated with their prostate cancer, they had a worse outcome. And finally, if they had bone scan progression. That bone scan progression, I explain it is that not just their PSA is rising, but on scans their disease is getting worse. If you look at the slide, that if patients have no risk factors and get started on chemotherapy, the median survival in the TAX-327 trial was 29.4 months. If they had 4 risk factors, the median survival was 8.6 months, which that suggests is that there is a different type of prostate cancer patient. And I utilize this as a way to who needs chemotherapy and who does not need chemotherapy. For example, if a patient who has castrate-resistant metastatic prostate cancer has no evidence of bone scan progression, but their PSA is rising, their CAT scan shows no evidence of disease in the liver, and that they have no pain symptoms and they're not anemic, they might be appropriate for clinical trials looking at new active agents. Or they also might be appropriate for Provenge therapy, because that will also confer a survival benefit to them. But this is an exciting place for us to look at some clinical trials. Some of those clinical trials that are available include TAX-700, which is a CYP17 inhibitor, which takes advantage of further lowering the testosterone for patients based upon the adrenal axis, as well as recently learned that actually tumor cells themselves also kind of self-fuel themselves with testosterone. In addition, another new drug, tasquinimod, which takes advantage of anti-angiogenic properties, is also an effective agent. Any new combinations that look at trying to prevent and delaying the symptoms of disease and prolonging life are useful. Another very exciting drug is MDV-3100. MDV-3100 is being looked at in a variety of spaces along the clinical states model. So MDV-3100 is an anti-androgen drug which shows some very exciting preclinical activity, which has moved into the clinical setting. They have completed the AFFIRM clinical trial, which was recently reported at the European Society of Medical Oncology, ESMO, in October of 2011, showing a survival benefit of 18 months compared to placebo for patients who receive docetaxel. This is very exciting. That says that previously, when we looked at drugs after chemotherapy, it's basically doubled the time of survival for patients after receiving chemotherapy. Also occurring is a clinical trial called PREVAIL. PREVAIL looks at MDV-3100 before patients have received chemotherapy. That clinical trial recently closed to United States accrual, but there are other opportunities for patients to take advantage of getting MDV-3100. First, there's also a clinical trial with MDV-3100 comparing MDV-3100 versus Casodex, which is a great question to answer because they're both anti-androgen-like molecules, and we'll find out which one is better, Casodex or MDV-3100. And so with MDV-3100, because it's so exciting, we're moving it along the spectrum of the disease. Very exciting that we'll be opening a clinical trial in January of 2012 with MDV-3100 combined with docetaxel. It'll be the first study of its kind in the country of studying this combination. It's a phase 1 trial ensuring that this is a safe combination to utilize, but it'll be an exciting opportunity for patients who need chemotherapy and combining it with a drug that appears to be very active. That phase 1 clinical trial will only be available at Virginia Oncology Associates as well as Memorial Sloan Kettering Cancer Center. So what patients might benefit from chemotherapy? Well, previously we talked about the importance of PSA nadir. When we look back at the clinical trial SWOG 9346, these were patients who had received androgen deprivation therapy and looking at the influence of how low the PSA falls and in terms of this prognosis. Well, if the PSA fell less than 0.2, the median survival was 75 months. And this is in the era before before chemotherapy was shown to be effective. If the PSA fell between 0.2 and 4, the median survival was 44 months. However, if the PSA after 7 months of androgen deprivation therapy was greater than 4, the median survival was 13 months. And how I utilize that in clinical practice is, if these patients are showing that they are castrate resistant or primary hormone refractory, then they need aggressive therapy. Going through stepwise hormonal manipulations such as Casodex or ketoconazole probably is not the most effective options for these patients. What we don't know with these exciting new agents that are coming forward, will these be beneficial? However, most of these clinical trials are with placebo, and I would be hesitant to use a placebo-arm trial for patients who have poor prognosis. So let's explore the importance of pain in predicting patients who might need chemotherapy. It is my premise that patients who have pain probably need chemotherapy, partially because that docetaxel has shown to decrease pain in these patients. So when you look at that trial in detail, that patients, when we retrospectively reviewed, 81% of patients made it to second-line therapy. And those things that predicted patients getting to second-line therapy was if they had pain. So if you look at patients who did not receive second-line therapy, most 67% of patients had narcotic treatment, and they were requiring pain medicines for the above. And the median survival who did not receive second-line therapy was 16 months. For those who received second-line therapy, it was 23 months. This helped begin my process of appreciating pain as an important component. Well, you don't necessarily have to believe me in my prior experience, but if you look at the data closely with TAXV27, it also suggests the same. So in subgroup analysis of TAXV27, the median survival of patients who did not have pain was 22.3 months, and patients who did have pain was 15.5 months. That also corresponded to mitoxantrone, which was the comparative arm in the TAXV27 trial. And so pain is a very important prognostic factor for patients. And if patients have pain, they likely need to be on chemotherapy. In addition, ideally, working with the urologist, working with the radiation oncologist, it'll be important to time the appropriateness of therapy to get the disease under control, hopefully before patients have pain related to the prostate cancer. The other important variable with prostate cancer is the PSA doubling time. This slide kind of summarizes the importance of PSA doubling time in terms of the overall survival, again looking back retrospectively at the TAXV27 trial. If the PSA was greater than 114 and the PSA doubling time was less than 55 days, approximately 2 months, then patient's survival was 13.8 months. However, if the PSA was less than 114 and the doubling time was greater than 55 days, approximately 2 months, the survival was 24.7 months. So these are other variables that you can factor in terms of who needs treatment when. And so when your patient's PSA doubling time, as most of you know, starts to explode, then they might need more aggressive strategies. The other important new advances in prostate cancer are new agents that have entered the market. One, the first new drug approved following docetaxel was cabazitaxel, which is also a taxane, which was shown, when compared to mitoxantrone, showed a survival benefit for patients following docetaxel use. And this drug was approved for prolonging the survival for patients. In addition, abiraterone was another drug that was approved. Abiraterone is very exciting because it's another CYP17 inhibitor that has been shown to be efficacious for patients with metastatic prostate cancer. The initial approval was for patients following docetaxel, this drug plus prednisone, abiraterone, also known as Zytiga plus prednisone, has shown to be beneficial. This drug was approved in 2011 and is shown to be very exciting for patients. We still await the results of the efficacy of abiraterone before chemotherapy. Again, the use of these drugs of abiraterone is still experimental before chemotherapy, though phase 2 clinical trials are highly suggestive that it will also be effective prior to chemotherapy. This is an exciting time for patients with castrate-resistant metastatic prostate cancer. There are multiple new drugs that are available, including Provenge, abiraterone, and cabazitaxel, and the likely approval of MDV-3100, hopefully in 2012. All these drugs are very exciting in order to help fight this disease and hopefully have patients live a longer life with improved quality. It is important that we continue to collaborate with the radiation oncologist, medical oncologist, as well as urologists in terms of coordinating the care.